Selamat siang, selamat datang di the 32nd Virtual Weekend Course on Cardiology 2020. Mari kita dengarkan lagu kebangsaan Indonesia Raya. Indonesia airku, tanahku padaraku, di sanalah aku berdiri, jadi pandu hidupku. Indonesia kebangsaanku, bangsa dan tanah airku, marilah kita berseru, Indonesia bersatu. Hiduplah tanahku, hiduplah negeriku, bangsaku, rakyatku semuanya. Bangunlah jiwanya, bangunlah badannya, untuk Indonesia Raya. Indonesia Raya, merdeka, merdeka, tanahku, negeriku yang ku cinta. Indonesia Raya, merdeka, merdeka, hiduplah Indonesia Raya. Indonesia Raya, merdeka, merdeka, tanahku, negeriku yang ku cinta. Indonesia Raya, merdeka, merdeka, hiduplah Indonesia Raya.
COVID-19 has become a global health burden with more than 21 million cases all around the world. And it is well known fact that people with cardiovascular disease have higher risk of morbidities and mortalities should they be infected by the virus.
In 2018, Indonesia's basic health research revealed that at least 1.5% of Indonesia's population has cardiovascular disease, a daunting number on its own. Fortunately, cardiovascular science is rapidly developing with so many advancements in recent years.
Weekend Course on Cardiology is an annual scientific event with a long and distinguished tradition in Indonesia's Cardiovascular Society. Regretfully, due to the COVID-19 pandemic, we cannot hold it live as per usual. Hence, we proudly present this year's event as the first virtual week of conference in Indonesia.
As we transform the 32nd week off into a virtual meeting, we offer you the very same vibrant scientific session with milieu of opportunity to reflect and connect over various innovations in cardiovascular medicine. We strive to make sure the virtual experience will not diminish the enthusiasm in providing refreshment of knowledge to cardiologists, general practitioners, as well as paramedics.
The 32nd week off will be held from 11th to 20th of September 2020. This event will be divided into 10 segments and 14 workshops. We also provide a designated forum to discuss various interesting cases and appealing scientific abstracts.
We gladly offer cardiologists, residents, general practitioners, medical students, and paramedics the opportunity to learn and discover the state-of-the-art innovation in cardiovascular medicine.
As Charles Mayo said, the safest thing for a patient to be in the hands of men engaged in teaching medicine. In order to be a teacher of medicine, the doctor must always be a student. This should be the spirit for all of us as a lifelong student of science, in which the absolute truth of today is always the relative truth of tomorrow.
We hope this event will serve as the alignment for those Huyen for the updates in the cardiovascular medicine from all over Indonesia. Welcome to the virtual
32nd week of
2020.
Saya boleh mulai bicara?
Silakan dokter.
Ya. Good afternoon, ladies and gentlemen. Good afternoon to all participants and also to the organizer. Thank you for giving me the opportunity to be the moderator or chairman of this first plenary session. We will have two speakers. First is Professor Balu Vaidyanathan from India, and the second is we're talking about fetal echocardiography, and the second is Dr. Anwar Santoso, which will be talking about COVID-19. Professor Balu is a clinical professor, pediatric cardiology, head of fetal cardiology division, Amrita Institute of Medical Sciences, Kochi, Kerala, India. And Dr. Anwar Santoso is staff of the Department of Cardiology and Vascular Medicine, Universities of Indonesia, and also staff of the Cardiovascular Prevention and Rehabilitation Division of the National Cardiovascular Center Harapan Kita. I think we will start with the first session, which by Professor Balu, with the title of the feasibility and impact of developing of dedicated fetal cardiology referral network and service in low middle income country settings. Please, Dr. Balu. Good afternoon, Dr. Balu.
Hi. Hello, Dr. Poppy. Can you hear
hi.
me?
Nice to meet. Yes, nice to meet you again.
Okay.
But on
Thank you
virtual
so much.
now.
Thank you so much. I saw beautiful pictures of Indonesia in that video, and I hope one day I can come back very soon.
Yes.
It's such a beautiful place, and So I'm going to share my screen. Can you see my screen now?
Yes, I see it now.
Okay.
Your slide, yes.
Okay, fine. Okay, fine. So may I start my presentation now,
Yes,
Dr.
please.
Poppy, with
Yes,
your
please.
permission? Okay, right. So thank you very much, Dr. Poppy, Dr. Fifi, and everyone, and all my friends in Indonesia. I hope you are all well, healthy, and it's been very difficult times for all of us. So it's a great idea that we are doing these programs, the webinars, so that our educational activities can move on without any interruption. So what I'm going to talk in the next 20 to 25 minutes or so, the next 25 minutes is about the feasibility and impact of establishing a fetal cardiology referral service in low and middle income country settings. LMIC stands for low and middle income country setting. This is basically countries like India, Indonesia, all are classically categorized as low and middle income countries. So we have developed a model in the state of Kerala in India, and I'm going to share some of our experiences in creating this. So the contents of this lecture shall include a problem statement about congenital heart defects. I will speak from our context to begin with and then generalize it. Then we will talk more about the Kerala model, how the prenatal heart screening model evolved. And then most importantly, I shall discuss the impact of developing that model in Kerala, which is why this lecture is all about. And there are messages for everyone in the world, and hence I feel that this model can be scaled up to many other countries so that numerous patients across the globe, particularly in places like Indonesia, can be benefited. Now we know that In India, the population is about 1.4 billion, and we have about 20 million births every year. So it is estimated that in our country, about 250,000 babies are born with congenital heart defects every year. And they have estimated that of this 250,000, about 100,000 will require surgery within the first year of life. And within the first 1 month, that is newborn babies, about 37,000 babies need surgery every month in the first month of life. So these are very large numbers, and I'm sure that in Indonesia, the problem is likely to be very similar, because I understand that the population is very high, even though not as high as India, but the growth rate in Indonesia is also very high. So in India, when we looked at the national perspective, and this picture is showing the map of India with the infant mortality rate. And there are certain parts of India, like the northern parts, which have still a very high infant mortality rate. But when it comes to the southern part, and that is where I have highlighted, that is Kerala. And Kerala has an infant mortality rate of around 10 and maybe even lower. So when the infant mortality rate comes down, when it is lower than 20 particularly, the impact of pediatric cardiac care becomes more and more. Then congenital heart defects become an important cause of mortality in infants. And that is the reason why when you look at the distribution of pediatric cardiac centers in India, when you see the whole map, you see the largest number are clustered in Kerala, in the single state. So this is some pictures of Kerala. It is called God's own country by some people. We have a lot of beautiful sceneries in this place, including hills, waterfalls, backwaters, beaches, and a lot of cultural activities, as what we can see as well. So the scenario is that it's not just a beautiful place, it's also beautiful with respect to its health statistics. In Kerala, the population is about 35 million. The infant mortality rate is about 10, and now it has fallen below 10 as well. The female literacy is very high in Kerala. The life expectancy is one of the best in India. And the most important point is that all women, pregnant women, have access to antenatal care. And almost all deliveries happen in institutions. We have 6 medical college hospitals under the government in this state. And there are 7 centers offering pediatric cardiac care. 5 of them are in the private, and this is how they are distributed. 3 centers are in the central part of Kerala. Cochin, where I practice, is the central part where these stars are being shown. Then there are a few others in middle Kerala, one in the southern Kerala, and then one in northern Kerala. So for the small state of 35 million population, we have 7 pediatric cardiac centers, of which 5 are offering newborn heart surgery. Now, this is the most important statistic which actually led us to initiate the fetal program in our center. The government of Kerala has started a program called Hridayam, which means heart, for treating children with congenital heart defects. And they estimated that about 4,000 children are born with congenital heart defects every year in Kerala. And 1,300 are critical, and they need surgery, but only 500 heart surgeries were taking place before the scheme started. And they estimated that about 25% of infant deaths in Kerala was because of congenital heart defects. Hence, the program was initiated. Our center was established in 1998, and it is a 1,500-bedded university hospital. The pediatric cardiology services were started in 1999. And we do about 700 pediatric heart surgeries every year, of which about 25% is newborn. This is a picture of my university hospital. What we identified from our database was this. So we have a database called the International Quality Improvement Collaborative, which is an international database which report to a central database in Boston. And over the first 7 years after this was established, we did about 4,700 surgeries. And when we looked at the mortality, we identified that the highest mortality was occurring in the newborn babies, as we can see in this graph. So overall mortality was 2.7% in the beginning and 2.3% in the second part. But for newborns, the mortality was 9% in the first era, 2010 to 2013, and 6.9% in 2014 to 17. So the highest mortality of all heart surgeries were occurring in the newborn babies. So this was the starting point. Then we looked at the factors which determine the outcome of infant heart surgery in our setting, limited resource setting. And this was a paper which was published from our center in seminars in thoracic and cardiovascular surgery. And in this, what we identified was preoperative status was very important. And that was the strongest predictor of adverse outcomes after infant and newborn heart surgery. Preoperative condition, preoperative bloodstream infection, and need for mechanical ventilation were strongly associated with adverse outcomes. So newborn heart surgery has a highest mortality, and the major factor affecting the mortality was a preoperative status. Then we looked at data of newborn transport from 2000 over a year period. We looked at all the patients who were newborn babies who were transported to our center. And what we picked up from this was that a large number of patients were transported without initiation of life-saving drugs like prostaglandin. And by the time they reached our hospital, a considerable number of patients had end organ injury in 42%, metabolic injury in 24%. So we could identify a sequence. Newborns are the most vulnerable age group. The preoperative condition affects mortality after surgery significantly, and transport, which is not very well done or poorly planned transport, was one of the major factors contributing towards a bad preoperative condition. So we are identifying a sequence, and let us put this sequence now into perspective and try to identify the new paradigm. So for newborn babies to reach the cardiac center, first a pediatrician or a neonatologist has to suspect that the baby has a heart problem. Then somebody has to do an echo in the local hospital to diagnose the problem. Then the baby has to be referred to a cardiology center and transported, which is a very crucial link. Then the child reaches a cardiac center, the preoperative stabilization has to be attempted, and then we have to do the surgery. So this is a normal sequence. And we identified that this is a danger zone. That is the diagnosis, referral, and transport before the child reaches a cardiac center. So if you have prenatal diagnosis, then we are eliminating all these links in the chain. And hence, the baby, if the baby is delivered in the cardiac center, the preoperative condition is likely to be much better, and hence the surgical outcomes are also going to be better. And that is how we identified this new paradigm. And with this, we initiated the program, but way back in 2018. But that was a very sort of, I will say, a half-hearted attempt to start a fetal cardiology program. We had only a part-time consultant, a shared medical social worker, shared equipment, and everything was shared. But what we did was we identified that this is benefiting our patients somewhat, even though the numbers were smaller. So the problem which I faced in the beginning was there was no awareness about fetal heart screening amongst obstetricians and many doctors. The guidelines, even though they were available, were not strictly adhered to. Infrequent conduct of ultrasound examinations, the mid-trimester anomaly scans were considered to be luxury investigations, mainly meant for high-risk pregnancies, not for regular pregnancies. And also many people believe, especially the obstetric community, believe that congenital heart defects, the treatment is futile and expensive. So most people were terminating the pregnancies without even referring to a pediatric cardiologist. So these were the guidelines which were available, but again, the adherence to the guidelines were not very strict. So this data actually showed that standard mindset. This is from our own state. And what they reported is that of the 310 cases of congenital heart disease diagnosed, including several cases which were correctable, like more than half of them had isolated cardiac defect with good prognosis. But in 75% of these from this center, the pregnancy was terminated. So this was the mindset. So generally amongst the non-pediatric cardiology community, congenital heart defects were considered to be not worthy of being pursued for correction and treatment. Hence, most pregnancies with affected defects were terminated. So what we did was we escalated our program to a full center of excellence in 2012 because we saw that this is important. This can save lives. So we started a dedicated fetal cardiology service. So I do my clinics twice a week in my center. And we also initiated several outreach programs where we go out and do the screening services. We appointed dedicated staff and counselors. We established databases with strict follow-up actions for patients. And we also got a dedicated equipment. And now I use the Volison machine by GE for my fetal echo studies. And what I did was, this is a program, the pediatric cardiac program. We have pediatric cardiology, pediatric cardiac surgery, and intensive care, which form the three legs of the tripod of the program. And we just merged the fetal cardiology program with this mainstream program, so that now we work as one single program. The prenatal service offering the prenatal diagnosis, counseling, preparation of the family, and planning the delivery with obstetricians in our center, and then the baby immediately goes into the mainstream program. So we have a rapid and transfer of data and information about patients through our social media groups, WhatsApp groups, so that everybody is aware that, okay, a prenatal case is going to be delivered in our center. We started this very large awareness building programs, and over this 7, 8 years, I did about 300 lectures, several training workshops, something like more than 50 in India, and now we started in Indonesia as well. Several educational events, which is called the Fetal Heart Series. Then we collaborated with professional bodies of obstetrics, radiology, and fetal medicines, the Society of Fetal Medicine in India, the PCSI, the Pediatric Cardiac Society of India. So we started collaborating for training with all these professional bodies, and we started to see the initial results by 2015. So we had 121 babies who were delivered in our center, and of which 33 newborns required surgery. And we found in our initial experience that all babies with the prenatal diagnosis who were delivered in our center survived the operation with no mortality. So this was extremely encouraging, and hence we approached the government with these results, the government of Kerala, and initiated a state-level capacity building program for obstetricians and radiologists. So this was initiated in collaboration with the government, in association with government of Kerala, and was supported by the Children's Heart Link, which is an NGO from US supporting our activities. And this program, I conducted 6 workshops in our state, and each of these workshops had lectures, live demonstration, and we also provided hands-on training to the obstetricians. So through these workshops, these are some of the pictures of the workshops which I did in the medical colleges, and we trained a total of 521 doctors, mostly obstetricians and the radiologists, in fetal heart screening. And we brought up this resources for training and learning. So what you see, the pictures, that is a flashcard for fetal heart evaluation, which we created for the government of Kerala. And all the obstetricians now have this flashcard of the normal heart and how they should do a normal fetal heart screening. We also came up with this resource booklet for fetal heart evaluation, which is also now distributed to all government doctors through the government of Kerala. So the training part. Now, the other part was also the economic factors. Now, this is the paper which my colleague, Dr. Krishna Kumar, whom you are all familiar with in Indonesia, he published this data, and he clearly reported that the economic impact of congenital heart surgery is very, very high for the affected families. So what we did, in addition to bringing up the awareness and skill of the doctors, is that we also work towards providing funding support for pediatric cardiac care. So we have many schemes now in our center, including the first one is a universal health coverage scheme by the government of India. This is called the RBSK scheme. In Kerala, the scheme is called Hridyam, which means the heart. Several NGOs are supporting us. Then hospital itself has got charity services, and we have partnered with the Children's Heart Link for education. So by combining the training and awareness building along with the providing funding support for pediatric cardiac and newborn cardiac care, we developed a new model of care. And this is a new model of care. So this is a present fetal cardiology division. So we have prenatal services with fetal cardiology. A comprehensive evaluation is done for all affected pregnancies. My fetal medicine colleague looks at the other organs. If somebody needs a genetic evaluation, we do the amniocentesis and the genetic workup. We have prenatal genetics. One of the world experts in pediatric genetics, Dr. Sheila, is with us. We have a department of high-risk obstetrics, which coordinates its deliveries. Then we have the delivery room management with obstetrics, neonatology, and pediatric cardiology, and then the postnatal care, which is seamlessly provided by our pediatric cardiac services, heart surgery and intensive care, and the nursing services. So let us look at some of the results of what we have done in the past 10 years, particularly the last 5 years. The first is the pickup rates. So before we started our work, there was no evidence or no data whatsoever about how many congenital heart defects in the newborn are picked up antenatally. Maybe less than 5% or less than 10% for sure. Now the number has improved. The critical heart defects, even though it is not ideal, about 20 to 25% are picked up in a population-based registry. In an institutional level, it is higher. So this is a significant improvement because 1 out of 5 is being picked up, and we are hoping that over the next 5 years, this 20% will become closer to 40 to 50%. Let me show you what is happening to our own center. The referral patterns, as we can see from this graph, significantly increase. Now look at the proportion of babies, newborn babies delivering with a prenatal diagnosis. That number is steadily increasing since 2012. Every year, the number is increasing. Last year, we had nearly 100 patients. That's 100 newborns delivering in our center with a prenatal diagnosis. The proportion of neonatal admissions with prenatal diagnosis in our center, it is 40%. In the government, the state registry, it is 20%, because in our center, it will be a skewed picture because of the availability of the expertise. More referrals may be happening to our center. And what is most interesting is that since the availability of prenatal diagnosis, proper counseling, availability of care, and providing the funding support for care, termination rates after prenatal diagnosis has come down from a 40% before to just 20% now. Termination is permitted in India till 20 to 20 weeks, sometimes up to 24 weeks if more experts agree. But here, it's 20 weeks actually. The termination rates also have come down. Nowadays, people terminate pregnancy if you diagnose a heart problem before 20 weeks in India, only if the heart problem is very complex, like hypoplastic left heart syndrome. Other correctable problems, most people continue. The impact on in-hospital outcomes, the preoperative status. So we use 2 scores. The larger the score, poorer is the preoperative condition. And as we can see, the blue bar is the postnatal diagnosis, and the orange bar is the prenatal diagnosis. Prenatally diagnosed cases had much lower scores, which means that the preoperative conditions were better. The age at cardiac surgery, it was earlier for the prenatal group, significantly earlier for the prenatal group. And the mortality, the newborn heart surgery mortality, over this 10-year period, for prenatally diagnosed cases, the mortality was 2.9% against 9% for the diagnosis after birth. So we are seeing the results, a significant impact overall with respect to referrals, the proportion of newborns being delivered with prenatal diagnosis, the better preoperative condition, earlier age at heart surgery, and lower in-hospital mortality. So this is our paper which we published in the Cardiology in the Young, showing that prenatal diagnosis and planned peripartum care will improve the preoperative status in newborns with critical congenital heart defects. This was a prospective study, and this showed a significant benefit in the preoperative condition. So this is our data for TGA, which has now been submitted for publication, which is under review. We had 82 TGAs, of which 64 were born alive, and majority were delivered in specialist cardiac center. 53 who were delivered in cardiac centers were operated, and 52 survived. The age at switch was just 4 days in prenatal case, while who were diagnosed after birth, the age at surgery was 11 days. The post-op mortality for prenatal cases was 2% against the diagnosis of postnatally is 3.6%, so almost half. The proportion of TGS with prenatal diagnosis increased, and this is the most important statistic. The mortality when the baby was delivered in a specialist center was very, very low. Just we can see this, the blue bar is a specialist center, like pediatric cardiac center. While if you deliver a TGA in a non-specialist center, look at the mortality, very high mortality. So we have made it a standard practice these days that when you diagnose a condition like transposition of great arteries, we always deliver the baby in the pediatric cardiac center, and the mortality after surgery is reduced to just 2%. So we also have been aggressively pursuing in utero therapy. So we published our data on fetal arrhythmias, a 10-year experience, and we had great success with fetal tachycardias with about 80%, almost 90% survived with good results. One case of in utero intervention which we did, that is the fetal aortic valve dilatation. I believe this is a very long way to go before it becomes a standard practice in most developing countries. Even in developed countries, this is a very big deal because most of these patients require a large number of procedures after birth. Right, so I spoke about all the positives, but let us now talk about certain other aspects as well. Now, we know that transposition has a great outcome with correction, but it is not the case with everyone. Now, when you look at the single ventricle subset of patients, that is where we do the Fontaine procedure as a final palliation, there are a large number of problems they face in the long run. So they have to live with a single ventricle throughout their life. So some of the challenges in the long-term management of the univentricular hearts are shown here. They need multiple procedures. They have risks, recurring costs, long-term issues like Fontaine failure, plastic bronchitis, protein-losing enteropathy, cardiac arrhythmias, thromboembolic complications, long-term organ dysfunction of the liver and the kidneys. Most of them require long-term medications, and the issue of neurodevelopmental sequelae. So, when you consider the long-term management of these patients, there are several challenges. So, we looked at our data of 504 fetuses with single ventricle during the period 2008 to 2018, and we looked at the pregnancy and the early postnatal outcomes. So, we had 504 cases. Only 215 had live births, which is about 42%. The remaining did not continue the pregnancy, of which only 25%, less than 25% of the patients had an intention to go for cardiac care. So for 504, the intention to treat became 119, which is just 23.6%. 35 patients required stage 1 palliation, 51 underwent Glenn, and only 17 have completed Fontaine till now. And on last follow-up, 21% were alive. So which means that those with intention to treat, 119 patients with intention to treat, 106 survived. But there was no intention to treat in about more than 75% because the families were not willing to either continue the pregnancy or go for postnatal care because of the long-term issues which we discussed. So this is how the numbers started
You have
to
5
fall.
minutes more.
Yeah, I will complete. So when this is converted into the costs. So completing a single stage, 3-stage palliation for single ventricle in Kerala, the amount is about rupees 4 lakhs. And when we extrapolate this to the number of patients who are born, and if there is no intention to care, and if prenatal diagnosis can actually give more options to the families, the overall cost savings will be about $1 million in Kerala alone. So there is a potential to redirect these funds to the care of more correctable CHDs like TG. Now, can we scale up this model to other places? In India itself, 10 states can scale up because their IMR values is less than 20. In South Asia, Maldives, Sri Lanka all have low IMRs. A lot of Asian countries like Indonesia, Thailand, Malaysia, Philippines all have low infant mortality. So this model of fetal care is something which can be taken up by a large number of places in Asia, including Indonesia. And how do you actually develop this model? So we need to have a primary screening for CHD in all pregnancies, which needs to be done by obstetricians and trained medical officers. Then you need regional experts who can confirm the diagnosis, provide an initial counseling, and refer. So that is usually done by radiologists or experts in maternal and fetal medicine. And then at the tertiary level, we have the pediatric cardiac care, fetal cardiologist, and multidisciplinary team. And the key is to actually network them together. That is the success. There is no point in us working as individuals remote from each other, as silos. The key, what we did successfully was we actually linked the different components of the prenatal screening, diagnosis, and tertiary care together into one single model. And that is why the results, we could achieve the results what we got. So In a final slide, the summary can be as follows. The potential impact of fetal heart screening. If we screen all the pregnancies, the fetal heart, then we can give options of very complex heart defects like hypoplastic left heart syndrome, with multiple other associated problems like genetic syndromes. Depending upon the regional rules and regulations, options can be given. And if it's a critical correctable problem like transposition or coarctation or duct-dependent circulation, such pregnancies can be delivered in pediatric cardiac centers. Thus, we can optimize the resources and improve the outcomes with a significant reduction in both short-term mortality as well as long-term morbidity. So, this is a transposition baby who is recovering in the ICU, a prenatally diagnosed case. And as we can see from this baby's eyes, he is very bright and healthy little one who is going to say thank you for the fact that the diagnosis could be made prenatally and he could be delivered safely and he could be corrected with very good outcomes. So I would like to thank Dr. Poppy and the organizers for giving me this opportunity. I hope, yes, it's 1:10 p.m. and I think that half an hour slot I could adhere to. Thank you very much. If you have questions, I would like to take it now because I have to return to work for some emergencies. So if there are any questions or discussions, if we can do it now, it will be nice. Thank you.
Yes, thank you, Professor Balu. Well, for the plenary session, we don't. We don't have any question and answer. So,
Okay.
yeah. So if you have to do something, you have to work in your hospital, you can do it. Yes. Thank you very much. Anyway.
No problem.
Yes,
You.
I think
Thank
we
you
have to
much.
follow. We have to follow your network. That because with fetal echo, with early diagnosis, then everything will be better, and the survival will be higher. Okay. Thank you. Bye bye.
So may I leave with your permission now and
yes,
go back to work?
You can leave. Yes, back to work.
Thank you. Thank you very much. Thank you.
Ya, saya kira tadi sudah kita mendengarkan dari Profesor Balu. Kita akan lanjut ke yang kedua, yaitu Dr. Anwar Santoso yang akan bicara mengenai COVID-19, cardiovascular disease and COVID-19. Saya nggak tahu ya, kan ini Profesor Balu sudah nggak ada, jadi barangkali apa bisa pakai bahasa Indonesia atau mungkin lebih baik pakai bahasa Inggris ya. Silakan Dr. Anwar Santoso, please Dr. Anwar Santoso, you can start now with your talk about COVID-19.
Very good afternoon, everybody. So, dear colleagues and friends,
You have 30 minutes.
So, what I'm going to share with you this afternoon is regarding cardiovascular disease and COVID-19, implication for prevention, surveillance, and treatment. This global pandemic should be comprehended and mastered by all medical personnel because we all have an obligation to mitigate these pandemics. So the background of this slide, during the COVID-19 pandemic, major health services mitigating spread action and treating acute SARS. It has been CVD and metabolic disease are responsible for worst outcome of COVID-19. On the other hand, cardiac injury might occur as a consequence of infection. So we propose not to forget the cardiovascular disease during the pandemics and focus on 3 stages. The first one is the prevention, and then the acute phase treatment, and don't forget the rehabilitation. So estimating the risk of comorbidities in COVID-19 may promote the importance of improving survival of COVID-19 patients with comorbidities. Patients with the COVID-19 with cardiovascular disease, hypertension, diabetes, heart failure, chronic kidney disease, and even cancer have a greater risk of mortality compared to those without comorbidities. So if we look at this slide, that the relative risk is approaching 2, meaning that the patient with the comorbidities having the risk of twice to have mortality risk. And then, however, in light on the recent call to stop or to cease all elective procedures, there is a danger of oversimplification of procedural urgency. Consequently, many patients and medical personnel postpone this important procedure and will result in adverse patient outcomes. So, if we look data that the STEMI presentation and door to balloon time and the post-COVID-19, we could see actually that the incidence of late presentation was consistently higher in the post-COVID-19 cohort, regardless of which cutoff was used to define late presentation. The door to balloon times were significantly higher in the patient who presented greater than 12 hours after symptom onset in the COVID-19 cohort. And we know that the longer, I mean the door to balloon time, the worse the prognosis of the STEMI. Okay, this is the clinical stage of the coronavirus diseases. During the first days from this onset, patients typically present a first phase with symptoms resembling an upper respiratory tract viral infection characterized by fever and cough. Over days 8 to 12, there is a transition to inflammatory phase during which pulmonary symptoms such as shortness of breath might appear. In this patient progressing to the hyperinflammatory phase with lung involvement and the risk of ERDS is notable. During this late phase, patients are at higher risk of suffering from thrombotic and embolic event to the procoagulant stage. This slide presenting the clinical course and outcomes in critical ill COVID-19. The most common symptoms were fever, about 98% patients suffering from fever, and followed by cough and then dyspnea. Among the patients, we could see actually that it will be lasting about up to 14 days. Most patients had organ function damage, including 67% with ARDS, acute respiratory distress syndrome, and about 29% with acute kidney injury, and followed by acute cardiac injury, about 23%. This is called the MODS, meaning that multiple organ dysfunction syndrome, and the other organ dysfunction, whereas follow liver dysfunction, can be occur, and then hyperglycemia around 35%. On the right panel, we could see the meta-analysis for the incidence of cardiac injury in the setting of the COVID-19, which are calculated from binary random effect model analysis. And the forest plots depicts the comparison between the incidence of cardiac injury in ICU versus non-ICU. Hypothesis of the COVID-19 pathogenesis and immune response in cardiovascular injury. The spike protein is activated by the protein that is called the serine protease, which is highly expressed in the lung, renal, and GI tract cell and engage with the ACE2 receptors. And this receptor is highly expressed on respiratory epithelial cell for early entry into the host cell. It is port-entry. Early infection is characterized by viral replication and direct damage by the virus to the host cells. As infection progresses, pro-inflammatory signal upregulate inflammatory cytokine production by cells in the adaptive and innate immune system, leading to cytokine storm and multi-organ damage. So this stages is very dangerous for the patient. During hospitalizations, most patients had marked lymphopenia, and non-survivors develop more severe lymphopenia over time. And the white blood cell count and neutrophil counts were higher in the non-survivor than those in survivor. So once again, that lymphocytopenia is a very pathognomonic biomarkers of the COVID-19. This slide showing the temporal changes in laboratory markers from illness onset in hospitalized patients with COVID-19. And these temporal changes showing that actually interleukin-6 and serum ferritin. Differences between the survivor and non-survivor were significant over time. Baseline interleukin-6 and the serum ferritin level were significantly higher in the non-survivor than survivor, representing higher cytokine storm since the beginning. The left panel show the ROC, receiver operating curve representing the good accuracy of interleukin-6 and the dimers in severe COVID-19 patient. The incremental value of multiple biomarkers demonstrate the independent and joint detection of this biomarker in predicting fatal COVID-19 and interfacing between the inflammation and thrombotic events. The higher the level of the interleukin-6 and the dimers, the worse the clinical outcomes are. Once again, this is lymphatic inflammation in the lung from a patient who died from the COVID-19, and the gross appearance of the lung tissue suffered from ERDS due to the COVID-19. The right panel demonstrated microthrombi in the interalveolar septa of lung from such patient. It revealed slightly expanded alveolar walls with multiple microthrombi in the alveolar capillaries. Extravasate erythrocyte and a loose network of fibrins could be seen in the intra-alveolar space. This slide showing the very pathognomic CT scan of the lung tissue. And then the patient, I think, have a severe COVID-19. So numerous studies have reported acute cardiac injury as an important manifestation of the COVID-19. To date, acute cardiac injury was defined as cardiac troponin elevation more than 99 percentile alone, or a composite of troponin elevation or EKG and echo abnormality. The presence of the ACE2 receptor on the myocardium and vascular endothelial cell provide a viral podantry into the cell. Micro and microvascular thrombosis were observed in autopsy of the COVID-19 patient, and myocardial injury may be caused by oxygen supply and demand mismatching and hyperambulatory state leading to stress cardiomyopathy or Takotsubo cardiomyopathy. This is the case of the COVID-19 complicated with fulminant myocarditis reported by Zhang. As a 63-year-old male was admitted with pneumonia and cardiac symptom. The PCR confirmed as COVID-19 positive, and the troponin I level was elevated, and the adverse echocardiography demonstrated diffuse myocardial ischemia along with reduced left ventricle function and enlarged left ventricle dimension. On the day 10, the echo showed edema of the left ventricle and improved left ventricle function, and the last bed echo on the day 17 showing a normal left ventricle ejection fraction and the wall thickness. This is the good stuff of management of the COVID-19. Once again, this is an example of the small group of viral particles observed within the interstitial cell of myocardial of the COVID-19 patient. The red arrows indicated the most typical and easy to recognize viral particle whose size varies from approximately 70 nanometer to 120 nanometers. Morphology showed small differences with more or less prominent spike of the viral crowns. This slide showing our works with meta-analysis explore the association between the acute cardiac injury and mortality and the need of ICU care, ERDS, and severe COVID-19 in this pandemic. The meta-analysis was accomplished with the standard reporting of the PRISMA statement, and from about 157 available abstracts that had been systematically searched in PubMed, Scopus, and ProQuest, and Cochrane, we finally selected the 13th journal, the valid journal based on the eligibility criteria. The cardiac injury was associated with a higher mortality with a relative risk of 7.9. The higher the troponin level representing cardiac injury, the higher the risk of mortality in COVID-19. And using sensitivity analysis by removing one paper, the cardiac injury is still consistently associated with the mortality. Talking about the level of the troponins significantly associated with poor clinical outcomes. This finding are beneficial and should be considered in the clinical management, prevention, and surveillance in dealing with patient safety in the hospital, particularly in the setting of the global pandemics. Consequently, the severity of pneumonia poses a high burden to hospital care resources and a shortage of medical personnel. It is very important. Now we proceed to the acute cardiovascular care in COVID-19. This is the algorithm for triaging patient admitted to ER. Patient with mild stable diseases should be discharged from the ER as soon as possible, with the suggestion that to stay at home in quarantine if a COVID-19 infection is confirmed. Conversely, patient in need of hospital admission for acute cardiovascular disease with concomitant COVID-19 positive should rapidly undergo testing, be managed as COVID-19 patient until they have two negative tests within 48 hours. Patient in need of hospital admission without any evidence of COVID-19 can be managed according to the standard of care. This is the interaction between the SARS-CoV-2 and the renin-angiotensin-aldosterone system. The slide depicts the initial entry of coronavirus into cell, primarily type 2 pneumocyte, and then binding to ACE2 receptor. After endocytosis, surface ACE2 receptors downregulated, resulting in unopposed angiotensin II accumulation. And then local activation of the RAS system may mediate acute lung injury responses to viral insults. So conceptually, the ACE inhibitor in ERB can degrade angiotensin 1 and 2 to angiotensin 1 to 9 or to 1 to 7, which have properties of vasodilation, reducing fibrosis, reducing inflammation and thrombosis, as well as improving the pulmonary damage. There are some treatments available that may need to be adjusted when concomitant specific therapy for COVID-19 is initiated. And this is the concomitant condition associated with severe COVID-19, and majority of this disease actually need ACE inhibitor and ARB. This treatment are initiated during hospital admission, and potential drug-to-drug interaction are listed on the slide. And you could see here that beta blockers, warfarin, corticosteroid, and antiretroviral virus has some interaction with the cardiovascular disease medication. When possible, patients should monitor their own blood pressure as frequently as they would, using a validated home blood pressure monitoring. Additionally, there is no evidence to suggest that ACE inhibitor and ARB should be discontinued due to concern about COVID-19. Treatment of hypertension, when indicated, should continue to follow the existing guideline available. Most patients who are hospitalized will have more severe infection and be hospitalized for respiratory support. They are likely to be older with comorbidities. Among hospitalized patients with COVID-19 and coexisting hypertension, in patient use of ACE inhibitor and ARB was associated lower risk of all-cause mortality compared with non-user. This Kaplan-Meier curve showing that during 28 hours that among more than 1,000 patients observed. Then in the right panel, you could see the plasma angiotensin 2 level are increased actually in the COVID-19 patient and correlated with the viral CT values. The lesser the CT values, the higher the viral loads detected. This is a large center cohort of more than 16,000 patients recruited with failure with reduced ejection fraction. The study demonstrated that continuation of the ACE or ARB at the time of discharge after admission of heart failure was associated with lower 30-day, 90-day, and 1-year mortality rates, as well as the admission to the hospital. Once again, this is a retrospective cohort study recruiting about more than 50,000 patients, more than 65 years, hospitalized with pneumonia. And then statin and ACE inhibitor and ARB were associated with improved pneumonia-related clinical outcomes. So how about the CVD prevention and rehabilitation? So once again, after resolution of the acute phase, prior infection with COVID-19 may result in persistent manifestation of disease. The schematic depicts the concept of progression over time, divided into 3 stages: acute phase, convalescent phase, and chronic phase. Delayed myocarditis and even cardiac arrest may become up at the convalescent phase, and dyslipidemia and as well as lung fibrosis should be monitored and prevented in the long runs. This is the recommendation for CVD care in the COVID-19 era. There are primary CVD prevention, secondary, and tertiary prevention. So the 3 phases, there are, once again, actually all the program were based on current evidence, either prevention or acute care. Once again, this is the cardiac rehabilitation consists of assessment of dyslipidemia, optimization of glucose control.
5 minutes more.
Acute LV function, yes, okay, this is the last slide. And aerobic exercise program, I think, should be initiated. This meta-analysis recruited about 1,500 patients and 1,400 control, and we carried out a wide-ranging electric search to identify a valid published RCT on aerobic exercise. And aerobic exercise was associated with reduced NT-proBNP level in heart failure with reduced ejection fraction patient. And there were a lot of data demonstrating that lower the BNP, the better the prognosis of heart failures. So Dr. Poppy, a summary, patients with previous CVD face a greater risk of infection of COVID-19 and greatly affect the development and prognosis of pneumonia. COVID-19 will result in acute cardiac injury through several mechanisms, namely direct myocardial toxicity, oxygen supply demand matching, epicardial plaque rupture, cytokine storm, and macrovascular function and stress cardiomyopathy. Acute CVD care should follow this clinical practice guideline in the COVID-19 pandemic recommendation. Level of CVD prevention during COVID-19 consists of primary, secondary, and tertiary prevention, including rehabilitation. Thank you very much, Shindit.
Yes, thank you, Dr. Anwar, for your lecture. This is the lecture about COVID is, well, now is booming because we know that the COVID patient increase and more increase every day. So I think everybody has heard that the cardiovascular disease has a greater, patient with cardiovascular disease has a greater risk for this infection. And it is because of the acute myocardial injury. Is that right? So, and then while maybe because of the cytokine storm or other things. Okay, I think we have finished this plenary session with two speakers. First is about fetal echocardiography. Dr. Balu has mentioned about the importance of prenatal diagnosis, so the patient can be delivered at the if they have complete complex heart disease, so the patient can be delivered, the baby can be delivered in the cardiac center, in the special center or tertiary center for cardiovascular problem, and this will reduce the mortality rate of the baby born. So, and then the second is from Dr. Anwar Santoso about the COVID-19, about the risk of the cardiovascular disease as a greater risk factor for this disease and cause acute cardiac injury. I think that's all. We can close the session and hope that everybody agree and happy about hearing about these two special speakers, and hopefully we will meet again other time. And I think that's all. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang.